I can't believe I came in for something like this. I wonder what new acronym they're coming up with this time. CLABC? Sounds like a new disease.
Oh, hi, you must be Dr. Germs. I've heard so much about you.
I'm sure you have.
Have a seat, make yourself...
Huh?
Oh. Have a seat, make yourself comfortable. I'll be starting in just a minute.
Doctor, am I early? I thought we were supposed to start at 9 o'clock.
No, Dr. Germs, you're right on time. We're not expecting many today.
Looks like you're not expecting any other than me. Oh, this should be fun.
Now, as you may know, National Patient Safety Goal number 7 focuses on reducing the risk of healthcare-associated infections, and part of this involves preventing central line-associated bloodstream infections, or CLABC for short.
CLABC? Really, who comes up with this stuff?
I'm sorry, Dr. Germs, did you have a question?
No, Dr. Vention, I got it so far. CLABC. Please go on.
As I was saying, central line-associated bloodstream infections can be a serious problem. Approximately 90% of catheter-related bloodstream infections are caused by central lines, and 48% of ICU patients have a central line. Now, approximately 5.3 central line infections occur per 1,000 cath days. The mean prolonged length of stay for CLABC is 7 days, which contributes to 18% mortality with 14,000 to 28,000 deaths per year. Averaging cost is $3,700 to $29,000. Now, according to this graph, in 2006, the Johns Hopkins bundle was identified by Florida Hospital as the evidence-based model we would adopt to reduce the number of central line-associated bloodstream infections in the ICUs. The Johns Hopkins bundle combines the already established best practices of hand hygiene, maximal barrier precautions, the use of chlorhexidine for skin prepping, optimal site selection, line maintenance, and daily review of the line necessity that results in a better patient outcome through the prevention of central line-associated bloodstream infections. The successful implementation of the central line bundle in Florida hospital ICUs reduced the central line-associated bloodstream infection rate from 1.29 per 1,000 device days in 2006 to 0.51 per 1,000 device days in 2008. Now, as you know, there are two main types of line, short-term and long-term.
Wow, this is really rocket science.
Short-term lines are percutaneous and include subclavian, jugular, and femoral. Long-term lines are tunneled-like for dialysis and also include implanted ports and PICC lines. Today I'm going to cover the 6 main prevention practices we have adopted. Number 1 is hand hygiene.
Wash your hands.
That's right, Dr. Germs. I see our hospital-wide education efforts have been working. Number 2 is maximal barrier precautions upon insertion. 3rd is chlorhexidine skin antisepsis. 4th is optimal catheter and site selection and avoidance of femoral lines. 5th is central line maintenance. And last but certainly not least, daily review of line necessity. Let's start with the hand hygiene.
Oh yes, please do. Let's hear this one more time.
First, wash your hands for a minimum of 15 seconds with soap and water.
Happy birthday to you.
Very good, Dr. Germs. That's a perfect way to make sure you wash long enough. I do the same thing with my kids, and even myself sometimes, but in my head, of course. Or you can use all-care foam. Just be sure to cover all hand surfaces with the foam, rub it in, and allow to dry. However, soap and water must be used when hands are visibly soiled. Easy enough?
Got it.
Step 2, maximal barrier precautions. These are designed to minimize the risk of infection by preventing contamination. Anyone involved in the insertion must follow strict hand hygiene and also wear a mask, cap, sterile gown, and gloves. The patient should be covered with a large sterile drape from head to toe with a small opening for site of insertion. Everyone in the room must wear a mask.
I think I'm starting to get this.
Okay, step 3. For safety and infection prevention, the Joint Commission mandates the use of chlorhexidine skin antisepsis, such as ChlorPrep, unless contraindicated. Activate the applicator to ensure solution saturation of the pad. Then press the applicator against the skin and using a back and forth motion, scrub for at least 30 seconds. Do not wipe or blot. Finally, allow the solution to completely dry before puncturing the site.
Got it.
Now to step 4, catheter site selection and infection risk. Whenever possible, the subclavian site should be your site of preference. The femoral site has highest risk, so should only be used in emergent situations. When choosing the femoral site, please document the reason for doing so and remove it or replace it as soon as possible. Okay? You can see it has a checklist to ensure that everything is done properly. From checking the equipment, prepping the site, barrier precautions, hand hygiene, sterile gloves, gown, mask, catheter cap, and needleless valve placed on the lumens.
Oh, thanks. Just what I need. More paperwork.
And finally, you should perform daily review of line necessity. This will help decrease the risk of infection and prevent unnecessary delays in removing lines that are clearly no longer needed for the care of the patient. And that's it for me today. Relatively painless, right?
Pain is really subjective, don't you think?
I suppose. Thanks for coming.
Hi, I'm Dr. Cautions. Have you already started?
CME started at 9, not 10. We're just finishing.
Hey, don't worry about it. At least it was just a CME and not surgery. Let me give you the quick rundown. CLABSI, code for central line associated bloodstream infection. Patients stay longer, die more often, cost us more moolah. Joint Commission National Safety Goal number 7 is all about reducing CLABSI. Lovely name, yeah, I know. Anyway, our response is the Johns Hopkins bundle. It's an evidence-based model of best practices that helps reduce infection costs. Step 1, wash your hands. Soap and water for 15 seconds or Alcare foam. That stuff right there. Step 2, maximal barrier protection. This bag right here contains everything you need. You wear a cap, mask, sterile gown, and gloves. Got a large sterile drape for the patient. 3, chlorhexidrine skin antipepsis, also known as Chlorapep, for at least 30 seconds. No wiping or blotting. Allow it to dry completely. Step 4, catheter site selection. Wherever possible, go the subclavian route. The femoral has the highest risk of infection and should be avoided, and only as a last resort. Step 5, central line maintenance. Well, this ought to keep you in line. Right, Coach? Last step, daily review of line necessity. Woo! 60 seconds. Ah! He does it. The champion reigns supreme. The crowd goes wild. Oh, good Lord. Tough crowd. You guys need to lighten up. We are the champions. We are the champions. No time for CLABSI, 'cause we are the champions.